Hello, my name is Chase, and I've chosen nasopharyngeal carcinomas, or NPCs, specifically squamous cell nasopharyngeal carcinomas, as my research topic. I will be analyzing how the modalities of MRI and radiation therapy help to treat and diagnose patients with NPCs. Let's take a look. To begin, nasopharyngeal carcinomas, or NPCs for short, arise from the epithelial cells that cover and line the nasopharynx. 90% of all cancers arise from the epithelium, and actually it's the most common cancer in adults. NPCs typically affect the older population and are categorized into three different types: squamous cell, non-keratinizing, and undifferentiated. For the purpose of this research project, we'll be focusing on the squamous cell carcinomas, or SCCs. The disease typically originates from the fossa of Rosenmuller, which is a bilateral projection of the nasopharynx posterior and just lateral to the skull base. The disease usually metastasizes quickly to the cervical lymph nodes and can distantly metastasize to the bone, lung, mediastinum, and rarely the liver. The 5-year survival rate of a patient with type 1 NPC is around 60%. The cancerous cells can spread posterior and lateral along the walls of the nasopharynx to the skull base or forwards to the soft palate. Though typically, cervical lymphadenopathy, or lymph node enlargement, is usually the initial observation that a patient might be presenting with an NPC. We'll take a look at formal diagnosis and treatment next. The disease progresses quite aggressively, so when a patient presents with any of the following symptoms: lockjaw, nasal regurgitation, nasal paresis of soft palate, hearing loss, cranial nerve palsies, or excessive nasal bleeding accompanied with cervical lymph node enlargement, a biopsy is typically performed. A CT head and neck is then ordered to further visualize tumor size and invasiveness in the patient, followed by MRI for staging and soft tissue detail. Typically, radiotherapy and chemotherapy are combined in order to control or attempt to wipe out the cancer. I found this topic to be fascinating because the tumors grow from such an intimate, small part of your skull, and they infiltrate to the rest of your body via the lymph node system. I wanted to see how this type of cancer could be controlled, eradicated, or how a patient could be protected from potential chemotherapy or radiotherapy that they could undergo in order to control the cancer. For the purpose of this presentation, I have chosen to focus on MRI and radiation therapy, or radiotherapy, and discuss how each diagnoses and treats NPCs. Just as a quick review, here's a bit of information about how each modality works and what it's best suited for. To begin, MRI, or magnetic resonance imaging, uses a powerful magnet and radio waves to capture information. This modality is non-ionizing and largely non-invasive. The patient is placed in an extremely magnetic field, which then causes the protons in their body to align a certain way. Specifically, the protons associated with hydrogen atoms, A radio frequency is then emitted that causes these protons to temporarily spin out of control from the magnetic field that they've temporarily aligned to. After the radio frequency is stopped, the protons realign with the magnet. MRI sensors are capable of capturing the energy these protons give off as they struggle to realign with the magnet. Different substances have different patterns of energy signatures, and the MRI sensors can read these energies and convert them into an image. MRI is excellent for fluid-dense things such as soft tissue and muscle. Gadolinium contrast may be injected or consumed by the patient in order to enhance certain areas of anatomy. In contrast, radiotherapy uses high-energy radiation in the form of either concentrated beams from a machine, external, or radioactive materials inserted into the patient, internal. Either route may be used to shrink or kill cancer cells or relieve pain as a form of palliative treatment. The radiation works to break up the DNA of cancer cells, causing them to lose their ability to grow or reproduce, which in turn inhibits the spread of the cancer. Side effects can be as severe as radiation affects more than just the cells it targets. Short-term side effects can include hair loss, fatigue, and nasal nausea and vomiting, while longer-term effects can include heart and thyroid problems, hormone changes, and the potential risk of developing another type of cancer. Due to the higher risk of side effects, this modality is tightly regulated and controlled, and each treatment is precisely adjusted depending on tumor size, location, quantity, and severity. The origin of most NPCs, the fossa of Rosenmuller, or nasopharyngeal recess, can be extremely difficult to see. It's behind and above your soft palate and is surrounded by mucosal tissue and shielded by lots of bony anatomy. It also closely resembles glandular tissue on a CT. In the past, Biopsies and endoscopies have been utilized to detect suspected NPCs, then MRI and CT is applied to get a more detailed study. MRI now functions as the main exam in order to better diagnose and locate NPCs. It's excellent at assessing the small recesses where most NPCs originate, and when compared to CT, it offers a higher image quality regarding tissue differentiation and tumor invasion of other structures. For this reason, it's primarily used for tumor staging in order to plan radiotherapy treatments if the patient is viable. Physicians will use MRI to make sure that they have pinpoint accuracy of the tumor's location before moving on to radiation doses to the site. A patient presenting with concern for NPC would be referred to MRI and after initial lymph node biopsy. An MRI head would be ordered and the patient would ask to fill out a screening form. This form contains several questions regarding any implanted metal you might have, included but not limited to vascular shunts, inner ear implants, artificial joints, brain aneurysm clips, pacemakers, and other metallic materials. They will ask you if you have ever worked with sheet metal or have been injured with shrapnel, and finally, if there's any chance you are pregnant. It is not proven whether MRI has any negative effect on the developing fetus, but women should still inform the technologist if they think they might be pregnant. The patient is not allowed to bring anything metal into the room and should be given a gown to wear for the exam. Additionally, it's important to assess whether your patient might be claustrophobic, as the MRI machine completely encompasses them for the entire exam. Exams can range from 30 to 60 minutes and are extremely loud. Earplugs will be provided to protect the patient's ears, or they can listen to music. It's very important they remain still while the images are being taken, as MRI is extremely sensitive to movement. Radiotherapy is widely accepted to be the main treatment option for NPCs. It is typically combined with chemotherapy, and treatment plans are tailored to fit each patient depending on tumor size, location, possible side effects, and patient preferences and overall health. Prior to starting radiotherapy, it's important a patient see an oncologic dentist to be evaluated for tooth decay. I didn't know that radiotherapy could cause tooth decay, and for this reason, damaged teeth may need to be removed prior to treatment. Radiation is delivered in 2 phases at maximum total prescription of 60 gray, 1 centimeter around the primary tumor site, and continuously all the way inferior to the clavicles to include the lymph nodes. Eyes, brain, spinal cord, and brainstem are able to be shielded respectively. Patients may undergo several treatments, 4 to 5 days a week, and exams can last for 10 to 30 minutes. Before any treatment is administered, a simulation is organized by the patient's care team. They can help you find a comfortable position and ensure you will be laying on the radiotherapy table the same way every time. This helps the targeted area remain in the same beam every time and aims to reduce unnecessary radiation. Cushions and blankets may be utilized to help you hold still, and intended site might be worked with a semi-permanent marker for exam targeting. Another CT is done once planning simulations are through in order to exactly figure out where the tumor lies. Just like MRI, the linear accelerator that applies the beams of radiation is loud and it moves around you to target different angles to the tumor. The staff is also available via audio and video should the patient have any concerns during the exam. The patient may lie still and breathe normally for the duration of the exam. As our technology advances, so does the treatment and survival rates of our patients. Due to this cancer's aggressive tendencies and quick metastasis to the lymph system, an early diagnosis gives the patient the best chance at survival. In the past, endoscopy and biopsy have been the primary exams used for staging for tumors, as well as CT. Today, there have been copious amounts of research that support MRI as the best modality to evaluate NPCs due to their tricky location and critical surrounding anatomy. One particular study conducted by researchers in 2015 concluded that MRI had a 6 to 12% higher sensitivity for tumor detection than that of endoscopy or endoscopic biopsy. For this reason, following up with MRI after a biopsy, no matter the result, is of the utmost importance. Just as well, advancements in radiotherapy have also helped to improve the lifespan of patients with NPCs. When coupled with the newest and most effective chemotherapy regimes, radiotherapy doses have been able to be reduced to patients over time. Newer accelerators also allow tighter beams and more tightly focused areas able to be pinpointed by MRI beforehand to ensure less dose to surrounding structures. From what I've learned so far in my research of this topic, I would argue that both modalities are headed the right direction and becoming more involved with each other than in the past. I think we should continue integrating MRI as part of our targeting process for tumors being treated with radiation. Even though it wasn't the focus of this project, I also feel that coupling chemotherapy with radiation doses is advantageous due to the advancements in drug therapy and, over time, reduction of overall needed exposure of the radiotherapy. Speaking of reducing dose, I know that CT tends to run as a standard due to cost comparison and flexibility of scanners, but I would argue that starting with MRI first would save dose and provide better information. Contrast can be used just as CT does, and if you get better soft tissue detail, If they see the tumor has infiltrated the skull base or has become more involved in the bony anatomy, then a CT can be performed for further evaluation. But since follow-ups are mostly MRIs anyways, comparative films would be more valuable if the initial clinical presentation comparison was that of an MRI. To conclude, I think that based off current technological trends and research conducted, the survival rate of patients with NPCs is only going to increase. The best way for that to happen is for physicians and care teams to be mindful of radiation dose, early diagnosis, and preference for exams such as MRI that offer the highest possible detail and information of structures. I'm excited to see what the future brings for medical imaging, and I'm proud to be advancing my career in such an expanding field. Thank you.